Excellence in healthcare education and delivery has been the hallmark of our institution since its founding in 1911. Today, we delve into a critical yet often overlooked aspect of cervical spine pathology, instability. This condition, though relatively common, remains one of the most frequently missed diagnoses, posing significant risks to patient well-being. Over the next hour, we will explore the intricacies of cervical spine instability, equipping you with the knowledge and skills to identify, evaluate, and manage this complex condition effectively. Instability of the cervical spine is a diagnostic challenge that demands our utmost vigilance. Why is it so commonly missed? Several factors contribute to this phenomenon. Firstly, the presenting symptoms can be subtle and easily overlooked, particularly in the early stages. Secondly, the physical examination findings may be nonspecific, making it difficult to differentiate instability from other cervical spine disorders. Lastly, the reliance on standard imaging modalities, such as plain radiographs and MRI scans, can sometimes fail to reveal the underlying instability, leading to misdiagnosis or delayed diagnosis. To better understand the clinical presentation of cervical instability, let us consider how a patient might present to your practice. Typically, these individuals report chronic neck pain, often exacerbated by movement or specific positions. They may describe a sensation of weakness or instability, as if their neck cannot adequately support the weight of their head. Some patients may even experience audible crepitus or a cracking sound with certain movements, indicative of excessive joint motion. On physical examination, you may notice increased tenderness, muscle spasms, or restricted range of motion in the cervical spine. Provocative maneuvers, such as axial compression or distraction, may elicit pain or reproduce the patient's symptoms. While cervical instability is a relatively common finding among patients with chronic neck pain following whiplash trauma, it is an uncommon occurrence in the uninjured population. Understanding this epidemiological context is crucial for accurate diagnosis and appropriate management. The occurrence rate of whiplash injuries in North America is staggering, ranging from 70 to 329 cases per 100,000 people. This high prevalence underscores the importance of recognizing and addressing the potential consequences of such trauma, including cervical instability. While some patients recover uneventfully from a whiplash-type trauma, others experience persistent pain and disability. This variability in outcomes highlights the need for careful evaluation and tailored management strategies. Failure to identify and address the underlying instability can lead to prolonged suffering and suboptimal patient outcomes. Alarmingly, studies have estimated that cervical instability is missed or has a delayed diagnosis in 5% to 20% of cases. This statistic is particularly concerning, as standard imaging techniques such as X-rays, CT scans, and MRI may not always reveal the underlying pain generator in these patients. Furthermore, research has shown that up to 30% of patients with ligamentous disruption displayed negative results on static X-rays and CT scans. This finding underscores the limitations of traditional imaging modalities and the need for more advanced diagnostic techniques in suspected cases of cervical instability. The risk of developing chronic pain increases significantly if the clinician cannot identify the pain generator in cervical trauma patients. This scenario often leads to a nonspecific diagnosis and incomplete or improper clinical care, perpetuating the patient's suffering and potentially exacerbating the underlying condition. The cervical facet capsule, the smallest and thinnest ligament in the spinal trauma complex, is also the most frequently injured and the least assessed. Disturbingly, none of the standard imaging protocols adequately assess the integrity of this crucial structure, necessitating the use of specialized views or techniques. Despite the widespread recognition of the importance of facet capsule pain among healthcare providers, it remains a frequently misdiagnosed and overlooked source of cervical spine pathology. Cervical instability can arise from acute trauma or long-term creep mechanisms. Overstretching or tearing of the facet capsule leads to excessive motion of the cervical vertebrae, disrupting the normal biomechanics and potentially causing neurological compression or pain. Several authors have proposed a strong association between chronic neck pain and cervical instability. This relationship highlights the need for careful evaluation and appropriate management strategies to address the underlying instability and alleviate persistent symptoms. Patients with cervical instability often present with radiculopathy or nerve root irritation, resulting from the encroachment of the facet capsule or surrounding structures onto the neuroforamen. These radicular symptoms are typically intermittent and exacerbated by movements such as rotation, flexion, or extension, which further compromise the already narrowed neuroforamen. Interestingly, MRI and CT scans in these patients may appear normal, further underscoring the diagnostic challenge posed by cervical instability. In addition to radicular symptoms, patients with cervical instability may experience audible, cracking, or popping sounds associated with excessive cervical rotation. This phenomenon is attributed to the laxity of the facet capsules, which are highly innervated by mechanoreceptors and nociceptive free nerve endings. As a result, the facet capsule itself can be a significant contributor to chronic cervical pain. Historically, patients with chronic neck pain following whiplash-type injuries have often been unfairly labeled as non-organic or accused of symptom exaggeration, malingering, or secondary gain. These pejorative explanations stem from a lack of understanding and proper diagnostic workup, particularly in cases of ligamentous laxity and cervical instability. However, the lack of cervical instability in the uninjured population, coupled with the common finding of instability in whiplash-type cervical trauma, renders these labels of pain exaggeration and malingering wholly unfounded. It is imperative that we, as healthcare providers, approach these patients with empathy, diligence, and a commitment to uncovering the underlying pathology. In a study investigating whiplash patients, 105 cases were evaluated using digital motion X-rays. Remarkably, 93 patients, or 88.6%, exhibited some degree of capsular injury. This finding highlights the high prevalence of capsular involvement in whiplash-related cervical trauma and underscores the importance of appropriate diagnostic modalities. Notably, despite the treating doctor's suspicion of ligament injury in these cases, none specifically mentioned capsular ligament injury in their assessments. This oversight emphasizes the need for increased awareness and education regarding the role of the facet capsule in cervical instability and chronic pain. It is crucial to distinguish between cervical instability and cervical hypermobility, as these conditions have distinct clinical implications. Instability typically presents with expected symptoms such as pain, radiculopathy, or neurological deficits, whereas hypermobility is classically asymptomatic. In the context of upper cervical instability, fractures, or metastatic lesions involving the upper cervical spine, you have learned about the rust sign. This sign, characterized by the patient supporting their head, especially when transitioning from a supine to a sitting position, is indicative of these specific pathologies. However, it is important to note that the rust sign does not apply to the more common mid to lower cervical instability, which presents with a different set of clinical manifestations. Imaging plays a crucial role in the diagnosis of cervical instability. While static X-rays and MRI may be insufficient to derive a precise diagnosis, video fluoroscopy has been found to be an effective modality in the evaluation of cervical instability, particularly in whiplash-type injuries. Cervical flexion and extension X-rays are valuable tools in the assessment of cervical instability. These dynamic imaging studies are associated with a very low false negative rate, making them a reliable diagnostic modality. It is important to note that in the acute phase following trauma, the utility of emergency room flexion and extension X-rays may be limited due to the patient's acute pain and muscle guarding. In such cases, patients have an increased risk of undiagnosed disc or ligament injury, necessitating additional imaging at a later stage. Current guidelines recommend obtaining flexion and extension films for awake and alert patients with persistent cervical tenderness. Even current guidelines recommend obtaining flexion and extension films for awake and alert patients with persistent cervical tenderness, even after negative plain films or CT scans. This approach aids in identifying potential instability that may have been missed on initial imaging. Instability is one of the most commonly missed diagnoses of the cervical spine. This statement refers specifically to the more prevalent lower cervical sagittal instability, not the less common atlantoaxial instability involving the upper cervical spine. The adage, "You will never find a diagnosis that you don't intentionally look for," holds true for cervical instability. If we do not consider this condition in our differential diagnosis, we are unlikely to pursue the appropriate diagnostic workup, perpetuating the cycle of missed or delayed diagnoses. A classic history of cervical instability often reveals patients who have experienced chronic cervical pain for years and have sought treatment from multiple healthcare providers without resolution. Typically, these patients report being evaluated by 3 or more orthopedic surgeons, 2 to 3 chiropractors, 3 to 4 physical therapists, and 2 or more acupuncturists. This pattern of care seeking should raise suspicion for an underlying, undiagnosed condition, such as cervical instability. Patients with cervical instability may report chronic neck pain, weakness, a sensation of their neck being unable to support the weight of their head, or audible, cracking, or sliding sensations with movement. It is crucial not to dismiss these symptoms as mere joint cavitation or self-manipulation, as they may be indicative of underlying instability. Upper cervical instability can manifest with a constellation of symptoms, including vertebrobasilar insufficiency, vertigo, tinnitus, arm pain, and headaches. In contrast, lower cervical instability may present with muscle spasms, paresthesia, crepitus, and chronic neck pain. Cervical instability is a significant issue that demands our utmost attention. However, can we reliably identify instability through palpation alone? Unfortunately, the chiropractic profession does not have a strong reputation for detecting instability through manual examination techniques. We are often guilty of missing this diagnosis, much like other healthcare specialties. It is essential to understand the anatomical constraints that contribute to the development of radiculopathy in the presence of instability. The cervical nerve root can occupy up to 72% of the neuroforamen space. If there is concurrent facet hypertrophy or decreased disc height, the available space for the nerve root becomes even more narrowed. When instability is added to this equation, the probability of radiculopathy occurring increases significantly. Instability is primarily detected through flexion and extension X-rays. Lateral flexion X-rays, also known as side bending views, may be helpful in certain cases. Video fluoroscopy can also provide valuable information, although it is not as commonly available. These imaging modalities may reveal vertebral body translation, excessive fanning of the spinous processes, or excessive flexion of one segment relative to another. Flexion and extension X-rays, along with a neutral lateral view, should be ordered more frequently than most clinicians currently consider. This practice is essential for identifying potential instability and guiding appropriate management. In evaluating instability, there are established criteria for interpreting flexion and extension X-rays. Sagittal translation greater than 3.5 mm or sagittal angular displacement exceeding 11 degrees in neutral or flexion positions is considered indicative of instability. These values represent critical thresholds that you must be familiar with, as they will be covered in your midterm and final examinations. The cervical instability checklist provides a comprehensive framework for assessing and diagnosing instability. The checklist includes the following criteria, each with an assigned point value. Anterior elements destroyed or unable to function, 2 points. Posterior elements destroyed or unable to function, 2 points. Relative sagittal plane translation greater than 3.5 mm, 2 points. Relative sagittal plane rotation greater than 11 degrees, 2 points. Positive stretch test, 2 points. Cord damage, 2 points. Root damage, 1 point. Abnormal disc narrowing, 1 point. Dangerous loading anticipated, 1 point. A cumulative score of 5 points or more is considered indicative of cervical instability. It is crucial to remain vigilant for the possibility of delayed onset instability. The muscle spasms and guarding associated with an acute injury may initially prevent an unstable segment from translating on the first set of imaging studies. If patients fail to improve as expected, it is prudent to consider repeating flexion and extension lateral views to assess for potential delayed instability. Additionally, in cases of side impact motor vehicle accidents or similar trauma, lateral flexion views, or side bending views, may be warranted to evaluate for instability in the coronal plane. Cervical manipulation should never result in symptoms such as headaches, vertigo, nausea, or vomiting. The presence of these symptoms may indicate a vertebral artery dissection, instability, or other serious pathology. If a patient experiences these symptoms following cervical manipulation, it should be treated as a medical emergency, and appropriate emergency management should be initiated promptly. While the presence of cervical instability does not necessarily imply that the patient is symptomatic, it is crucial to remain vigilant for early warning signs. Changes in deep tendon reflexes, the emergence of pathologic reflexes, or indicators of radiculopathy should be carefully monitored, as they may signify progressive or worsening instability. Patients with significant cervical instability require prompt referral to a spine surgeon for further evaluation and management. These individuals are at an increased risk of quadriplegia if they were to sustain another traumatic event, such as a motor vehicle accident. As healthcare providers, it is our ethical and legal obligation to discuss the clinical findings, risks, and the need for surgical consultation with these patients, ensuring they are fully informed and able to make an educated decision regarding their care. In conclusion, cervical instability is a complex and often overlooked condition that can have severe consequences if left undiagnosed or improperly managed. By enhancing our understanding of its clinical presentation, diagnostic modalities, and management strategies, we can improve patient outcomes and prevent potential catastrophic events. It is our responsibility as healthcare professionals to remain vigilant, maintain a high index of suspicion, and diligently pursue appropriate evaluation and treatment for our patients with suspected cervical instability.